Welcome to this Step 3 review on fracture management, brought to you by Roadmap to Residency. Fractures show up again and again on this exam, and the questions are rarely testing whether you can name the bone. They are testing whether you can look at the picture, decide what to do right now, and recognize the moment a case turns into an emergency. Today we are going to work through how these stems are built, how to read the film in plain language, when a splint is enough, and when you must pick up the phone and call the orthopedic surgeon. This is about strategy, not memorizing every fracture. Make sure you are also working through your question bank and a solid review resource alongside this video, because these patterns are best learned by doing many practice questions. Let us get started. Here is our plan for the next few minutes. First, we will read a fracture vignette the way a physician actually does, describing the film, deciding on immediate care, and knowing when a specialist has to be involved. Second, we will train your eye to catch the emergencies that hide inside ordinary-looking cases, especially compartment syndrome and the open fracture, because those are the ones that cost points and, in real life, cost limbs. Third, we will match the classic question stems to the single best next step, from a simple splint in the clinic all the way to an urgent call to the operating room. Throughout, remember that this video is about exam strategy. For the underlying orthopedic content, lean on your question bank and a trusted review resource, and let this video show you how to use that knowledge under pressure. Our first strategy is to describe the X-ray before you ever look at the answer choices. Say it out loud in plain words. Which bone is broken? Where along the bone is the break? And what are the two ends doing? Do they still line up, or are they angled or shifted? Does the skin look intact over the injury? When a stem hands you these details, it is quietly telling you what the correct answer has to deal with. Then hunt specifically for the findings that change everything. A fracture line that reaches into a joint, ends that no longer line up, or any suggestion that bone has broken through the skin. Those three details are the ones that push a case away from a simple splint and toward a specialist. Train yourself to look for them in every fracture stem. Our second strategy is the immobilize first mindset. For most simple, closed, and well-aligned fractures, the safe and correct next step is to immobilize the limb, control the pain, and confirm that the blood supply and the nerves to the fingers or toes are intact. On this exam, a stable fracture that is already in good position usually earns a splint and outpatient follow-up, not surgery and not admission. One key detail the test loves is the difference between a splint and a full circular cast. A fresh injury swells, so we splint first and save the tight circular cast for later. If you see an answer offering a snug circular cast on a brand new injury, be suspicious, because that is a planted trap that can choke off circulation. And always reassess the fingers or toes for color, warmth, and sensation after immobilizing. Now, the part that separates a passing answer from a dangerous one. Knowing when to call the orthopedic surgeon. There are three signals, and the test writers plant them deliberately. First, the fracture enters a joint. A break that travels into the joint surface needs precise realignment, or the patient is left with stiffness and arthritis, so the correct answer leans towards specialist evaluation rather than a splint alone. Second, the ends no longer line up. A clearly displaced fracture, or a joint that has come apart, needs an expert to reduce it. When the stem stresses that the fragments are out of position, favor the surgeon. Third, the skin is broken over the bone. That is an open fracture. And it is an emergency of antibiotics, a tetanus update, and an urgent call for surgical washout. Never let that be downgraded to a simple bedside splint. Let us work through our first practice question. A 60-year-old woman comes to the clinic after falling onto her outstretched hand. Her wrist is swollen and tender, but notice the reassuring details. The skin is intact, and her fingers are warm with normal sensation and movement. The radiograph shows a fracture of the far end of the forearm bone, the fragments are in good position, and the break does not reach the joint. The question asks for the most appropriate next step. Before you choose, run through our signals. Is the skin broken? Is it displaced? Does it enter a joint? Here the answer to all three is no. Read the four options carefully and pick your answer. Then we will walk through the reasoning together on the next slide. Let us reason through it. Spot the pattern first. Every detail in this stem is reassuring. The skin is intact, the fingers are warm and sensate, the fragments are in good position, and the joint is spared. That is the very definition of a simple, closed, well-aligned fracture with no emergency features. Now apply the rule. For a stable, closed fracture that is already lined up, the next best step is to splint the limb, control the pain, and arrange outpatient follow-up. So the correct answer is to apply a splint, provide pain control, and arrange follow-up. Finally, eliminate the wrong answers. The tight circular cast on a fresh swelling injury is the classic trap. Urgent surgery is far too aggressive for a well-aligned fracture with intact skin, and overnight admission just adds cost without changing the care of a comfortable, stable patient. Here is our second practice question, and this one is an emergency in disguise. A 20-year-old man had a lower leg fracture placed in a cast several hours ago. He comes back with severe, worsening pain that is far out of proportion to the injury and is not relieved even by strong pain medicine. When you gently stretch his toes, the pain surges, and the compartment feels tight and firm. The question asks for the most appropriate next step. As you read the choices, ask yourself whether this is a stem that rewards patience or one that punishes delay. Pay close attention to that pain out of proportion and the pain on stretching the toes. Pick your answer, and then we will walk through it together. This is compartment syndrome, and the exam wants to see if you recognize it and act. Read the warning signs. After a recent injury or a cast, you get pain out of proportion to the injury, pain that gets dramatically worse when the toes are passively stretched, and a compartment that feels tight and firm. Put those together, and you have a limb where rising pressure is choking off its own blood supply, and every minute of delay means more muscle lost. Now act without waiting for a scan. The correct answer is to release the pressure at once. Open or remove the cast, call the surgeon urgently, and prepare for surgical decompression. Reassuring him and sending him home, waiting on imaging, or simply adding a stronger opioid are all wrong because each one delays the only treatment that saves the limb. When the picture fits, you act. You do not image and wait. Let us step back to how you actually read the film, because a systematic routine catches the fractures that a quick glance misses. Walk the cortex first. Trace the smooth outer edge of each bone all the way around, looking for any step, gap, or buckle in that line. Then move to the nearby joints and check that the surfaces are smooth and the spaces between bones are even. A calm, repeatable routine keeps the obvious fracture from distracting you away from a second, subtler one. And always ask for two views. A single view can hide a break that only appears from another angle, so the standard is at least two views taken at right angles. On a stem, an answer that settles for a single view, or that jumps straight to advanced imaging before a simple plain film, is usually the wrong first move when you suspect a fracture. Here is our third practice question. A 30-year-old man is brought in after a motorcycle crash with a deformed lower leg. There is a jagged wound over the shin, it is bleeding, and you can see a fragment of bone within the wound. Reassuringly, his foot is warm with a strong pulse and normal sensation. The radiograph confirms a fracture right at the site of that wound. The question asks for the most appropriate next step. The moment you read bone visible within a wound, one of our three signals should be flashing. Ask yourself which emergency this is and what the correct bundle of care looks like. Read the options, choose your answer, and we will work through it together on the next slide. This is an open fracture and it is a surgical emergency. Name the emergency first. Bone visible within a wound or any wound sitting over a fracture means the broken bone is now exposed to the outside world and to contamination. The care comes as a bundle: early antibiotics, a tetanus update, a clean covering over the wound, and an urgent call to the surgeon for a formal washout in the operating room. Now the key distinction. The correct answer gives antibiotics and tetanus coverage, protects the wound, and calls the surgeon at once. Cleaning it in the clinic and sending him home badly underestimates a true emergency. A splint with routine follow-up ignores the exposed bone. And getting a scan before treatment dangerously delays the antibiotics and surgery that this patient needs. The answer is early antibiotics, tetanus, coverage, and an urgent surgical call. Before we wrap up, let us name the two planted distractor patterns you will meet again and again in fracture questions. The first is the overkill trap. For a simple, well-aligned, closed fracture, the exam dangles surgery, admission, or advanced imaging to make thorough care look like the right call. But when the injury is stable and the skin is intact, the proportionate answer, usually a splint with follow-up, beats the impressive-sounding one nearly every time. The second is the delay trap. In a genuine emergency like compartment syndrome or an open fracture, the trap is any choice that waits. Order a scan first, recheck later, or just add more pain medicine. When the stem paints an emergency, the correct answer acts now. Learn to feel the difference between a stem that rewards patience and one that punishes delay, and these questions become much easier. That brings us to your final tips and where to learn more. Drill these fracture patterns in your question bank until the next best step feels automatic, and read every explanation, even for the questions you answered correctly. Pair that practice with a trusted review resource for the orthopedic details, and keep working under timed conditions so the emergencies jump out at you on exam day. For more help, visit www.roadmap2residency.com, where our expert tutors and residency advisors can help you build a personalized study plan. If this video helped you, please like and subscribe for more board review content. Good luck on your exam, and we will see you in the next one.